I just want to thank Maureen's Park for making this great facility available to us. We've had a number of our meetings throughout the year here at some of your fabulous restaurants as well, and the service is just outstanding. The food is great. The staff is so cooperative, and it's just a pleasure to be at Maureen's Park. So right now I'm going to introduce our moderator, who indeed will introduce the panelists. He's Dr. Hiranya Rajasingh, and he's a vascular surgeon here in Naples and a 1988 graduate of the Yale Medical School. Dr. Raj?
Thank you, Mike. Good afternoon. I have the distinct honor of introducing our panel today, and again, Dr. Mary Tinetti, who was to give the first lecture, thank you, is not able to be here due to weather reasons, but Dr. Leo Cooney will give her talk. So in order, let me just introduce our distinguished panel. Dr. Tinetti is the Gladys Phillips Crowfoot Professor of Medicine in Geriatrics and Public Health, as is the Chief of Geriatrics at the Yale School of Medicine. Dr. Tinetti was the first investigator to show that older adults could reduce their risk of falls and fall injuries, thus avoiding one of the major contributors to functional disabilities. Her current research focus is on the net benefit and harms of commonly used medications for older adults in the face of multiple health conditions. She's also leading a national effort to develop and text an approach to healthcare decision-making that focuses on the individual health priorities of older adults with multiple conditions. She chairs a group of advisors helping large health systems becoming age-friendly. Dr. Tinetti has published over 250 articles. She has received numerous awards and is a member of the National Academy of Medicine and the MacArthur Foundation Fellow. Dr. Leo Cooney to my left is the Humana Foundation Professor of Geriatric Medicine at Yale University School of Medicine. Dr. Cooney established the program in geriatrics at Yale in 1976 and served as Chief of Section of Geriatric Internal Medicine at Yale, as well as the Chief of Section of Geriatrics. He was the president of the medical staff of Yale New Haven Hospital and is past president of the American Geriatric Society. Dr. Cooney has won multiple teaching awards from Yale medical residents and students. His research and teaching activities have been focused on assisting elderly individuals attain the highest level of independence possible. He is committed to ensuring that resident physicians and students at Yale are as prepared as possible to care for elderly patients. Immediately, I'll skip over to Brienne Miner. Dr. Miner is a geriatrician and sleep medicine physician and researcher interested in improving the management of sleep-wake symptoms in older adults. After receiving her medical degree from the State University of New York Downstate Medical Center, she completed further training at Yale University, specifically residency in internal medicine and clinical and research fellowship in geriatrics and a clinical fellowship in sleep medicine. Her current interests include investigation of insomnia symptoms and daytime sleepiness in older adults, as these are prevalent and likely to have adverse effects on important health-related outcomes. Ultimately, she aims to design interventions for symptoms of insomnia and daytime sleepiness in older persons with and without cognitive impairment, which may lead to improvements in cognitive and physical function. Finally, our last speaker is Dr. James Lai. Dr. Lai is the Associate Chief of Clinical Affairs for Geriatrics at the Yale School of Medicine and oversees a vibrant clinical program that includes 3 skilled nursing facilities, 4 primary care sites, a home-based primary care program, an inpatient consultation service, and the Keystone Adler Geriatric Assessment Clinic. He is also co-chief of the inpatient Cooney Firm service at the Center for Restorative Care at the Yale New Haven Hospital at St. Raphael's campus and serves on numerous system-wide committees dedicated to quality improvement and creating an age-friendly health system and he's also a fellow of Trumbull College on the undergraduate campus. As a graduate of Wake Forest University School of Medicine, Dr. Lai trained in internal medicine at the University of Maryland in Baltimore and went on to complete a fellowship in geriatrics and a clinical research fellowship with the Robert Wood Johnson Clinical Scholars Program, both at the Yale University School of Medicine. Dr. Lai brings a broad clinical experience to Yale, having practiced primary care in the community for 8 years, followed by 4 years exclusively as the inpatient hospitalist and floor medical director at Yale New Haven Hospital. Currently, he is focused on developing the geriatrics program at Yale to meet the clinical, educational, and research needs of the institution and growing population. We will begin with the first lecture that's going to be given by Dr. Cooney. This is how to get what matters most to you from your health care. And then he will be doing the second lecture, which is maintaining independence. We will have the questions and answers taken at the very end of all three speakers, and I'll be happy to help moderate that. Dr. Cooney, thank you very much.
Can everybody hear me okay with the microphone? It's okay? All right. So my claim to fame at Yale is that I recruited Mary Tonetti, and then I kept Mary Tonetti. And the reason that's so important is that Mary, who won a MacArthur Genius Award for her work in Falls, was recruited to be deans of schools and heads of programs, etc. She stayed at Yale, not because of me. She stayed at Yale predominantly because she wanted to continue her research. She was so concerned about how we care for older people. So she's gone from Falls, which she continues to work in, to the problem of sort of patient-directed care. So some of us collect stamps, others collect coins, others collect old books. But what we all collect as we age are diseases, all right? You basically get more conditions as you age. So the problem of caring for older people is you're caring for people with multiple conditions and how to focus your treatment on what the patient really wants as opposed to the condition itself or the numbers, if you will. Now I'm going to see if I can get this to work. Okay. So we're going to start with a patient that was part of Mary's study, Mr. Smith, and we're going to go by the numbers. He's 77, has 3 children, 5 grandchildren, 1 wife, has 6 chronic diseases, arthritis of his hip, diabetes, hypertension, etc. He's on 9 medications. He has 5 doctors. And that's a challenge, how those doctors interact with each other. Big part of what we're going to talk about today. And he actually has 2 health visits a week. But I mean by health visit, not necessarily a doctor's visit, but going to a laboratory or getting a variety of tests done. So a lot of his life is focused on that. And his doctors are always telling him his blood pressure is too high, his glucose is too high, and they're concerned about his conditions, and his orthopedic surgeon says your hip x-ray is bad, you need a hip replacement. But he's not sure about that. His real complaint is he's tired all the time. He can't do what he wants to do because he's so fatigued. He thinks he spends too much time on his health care, and he's not sure about this idea of surgery. So health care for persons with multiple conditions, it's a challenging because our ability to benefit people with multiple conditions is not that clear. Most research is done on patients with one condition or is focused on that one condition, not the 6, 7, or 8 conditions that so many older people have. The care can be burdensome. It may not focus on what matters most to the patient. So what do? Well, our answer, or Mary's answer, is find out what matters most and let your clinicians know about that. What's most important to you? But that's not quite so easy. It takes some challenging. When we look at older people and ask them what's most important to them, healthcare is not huge. It's about 25% of people are concerned about living longer. About a third of people want their symptoms relieved. But almost half of people focus on their function, their independence, their ability to care for themselves is appropriately very important to those individuals. So when identifying health priorities, Mary's looked at a lot of different areas. She's looked at connecting, and that is with family, friends, community, or church, or synagogue. Enjoying life, your productivity, recreation, personal growth, your function, your dignity and independence, and also maintaining your health and managing your symptoms. So as she's tried to do that, she's focusing on goals. What's most important to the older individual? And in looking at those goals, they have to be goals we can take action with. They have to be goals that are consistent and reliable, but they also have to be realistic. So what are the important goals? It may be babysitting and playing with a grandchild. It may be working half day and doctor's visits interfere with that. It may be working, doing ceramics or walking half a mile. But that can be difficult because they might be so fatigued, and that may impede their ability to do what they want to do. All right? So as we look at healthcare, what does it involve? It involves taking pills. It involves going in for visits. It involves some testing and procedures, and so what we call self-management activities. That is, fulfilling the exercise program or dietary program that clinicians might ask you to do. And when Mary asked different patients about this in her studies, they might get the answer, I get blood tests done every month, that's not bad. CPAP, which is continuous positive airway pressure, it's a treatment used for patients that have what's called sleep apnea. Sometimes helps. It's quite burdensome, though, okay? The patient may tell you they walk and do their exercises and that medication does help their acid reflux, okay? But just as commonly, or if not more commonly, what the patient tells you is that they're burdened by their health care. Their medications cause muscle pain, and it's hard to be active. Their sugars are too tightly controlled with their diabetes, so they get low blood sugars, so-called hypoglycemia and shaking. They have to check their insulin and glucose too often, and they don't want surgery, all right? So it's a little more complicated. So what we're trying to do is align care with what patients really want, all right? So how do we do that? Well, first thing is to start with one thing. So getting back to Mr. Smith, his major concern was not his blood pressure or his diabetes or his hip arthritis. It was the fact that he was tired all the time. He was fatigued. That was his major symptom. That's what really bothered him, all right? So then we need to look at what can we do to deal with that fatigue. It might be discontinuing some medications. It might be changing medications. It might be looking for a medical cause of that. But we want to focus on that symptom that is most important to the patient. We want to use that patient's priority, not so much their diseases, in decision-making and assessing benefit. We want to focus on desired activity. So what's the activity that Mr. Smith wants? He wants to be able to go to his club 3 times a week. And he can't do it now. He's too fatigued. He has to nap all day. That's his major complaint. Now, in dealing with that, we have to deal with American medicine in 2019. And that is the number of subspecialists or specialists that so many patients have. Collaborating with those people, communicating with those individuals to try to come up with approaches is very, very important. One study showed that when you go to see a cardiologist for the first time, you walk out with 5 prescriptions. So that's a big challenge. And we know that multiple medications causes a lot of problems. The primary care physician very often has to do a little discussion and negotiating with the specialist when trying to alter the medication that the patient is taking. So these collaborative negotiations, we have to agree on what information is important. We have to also agree that there's no right answer and get together and brainstorm a little bit about alternatives. Getting back to Mr. Smith, again, he wants to be less tired. He wants to get to his club a few days a week. His medications make him too tired. So his health care outcome goal is to get to the club 3 times a week. His preferences are to decrease his medications and to avoid surgery. So in Mary's program, she worked with the primary care physician and the cardiologist. We're able to decrease medications with the end result the patient was less tired and was able to get to the club. Working with the orthopedic surgeon, it became clear that the decision to operate on the hip should not be on the basis of the X-ray or MRI of the hip. It should be on the symptoms the patient has and the impact those symptoms have on that person's activity and lifestyle. So Mary went ahead and did a study. She actually used a group of physicians who were not affiliated with Yale, and in fact, they were affiliated with Yale's competitor, and that is the Hartford healthcare system, a group called ProHealth. And they were in a town called Bristol, Connecticut. Now, some of you may, Bristol was outside Hartford. About 40 years ago, a fellow named Dick Rasmussen decided that he would experiment with the idea of doing 24-hour sports programming. So we established what was called the Eastern Professional Sports Network. You may know it as ESPN. And now when you go to Bristol, Connecticut, that's all you see is ESPN. My sister's actually an associate, as an executive producer with them, so I know a little bit about it. But in any event, it happened that the group that Mary was working with was in Bristol. And she had 10 primary care physicians. Again, these are all physicians associated with one healthcare system, what's called ProHealth. So there were 10 primary care physicians, 5 cardiologists, 163 patients, and as in all medical experiments, you need a control group. So the usual care group was 7 primary care physicians and 203 patients. So what were the results of that study? Well, there was more focus on patients' goals. That's pretty obvious. But really importantly, what happened was 42% of the patients who were participating in this goal-directed care were able to decrease medications as opposed to 24% in the control group. 10% were able to avoid procedures versus 5% in the control group. And there was a significant decrease in what's called treatment burden in the experimental group. So basically, what Mary has demonstrated in this study was that focusing on patient goals, getting a collaborative relationship between primary care physicians and specialists, you can make a difference. So you're focusing not so much on the numbers of the blood pressure or the diabetes, you're focusing on what's important to the patient. So what are the next steps? Mary is working on doing studies in more areas and spreading the healthcare systems and teaching students and resident physicians more at Yale and elsewhere about sort of patient-directed care. When James talks to you later about the health-associated health systems, health-friendly health system, you're going to hear about the 5 M's, and one of them is what matters most. So it's really important as clinicians that we learn what is most important to our patient and focus on those goals as opposed to the abstract numbers that we deal with often in the practice of medicine. I'm going to stop there. Again, we're going to do questions at the end and slip over to my talk, all right? So you heard and you saw that when Mary looked at what was so important to older people, function was the most important thing. So we want to maintain our independence. We want to be able to care for ourselves. What can we do about that? How can we try to ensure that we stay as independent as possible? So when talking about independence, one of the major focuses of independence is mobility. That is getting around, all right? So as you're thinking about maintaining your independence, I would recommend one thing, that you listen to your body, that you pay attention when you start to have problems with your mobility. And if you have a problem, what component of mobility might be the problem and what might be the cause of that component of mobility and how might it be corrected? So what do I mean by components of mobility? What I mean is, what are those things we have to do every day to get through the day? We got to get out of bed first, okay? So you have to get out of bed. You have to be able to get off a chair or off a toilet, very importantly. Walking in a safe environment without falls is very, very important, obviously. And then if you live in New Haven, you have to learn about climbing stairs. Perhaps in Fort Myers and Naples it's less of an issue, but stair climbing is a major issue with older people, and particularly it's an area where falls do occur. So interesting, Neil Alexander did a study about 30 years ago at Michigan. So when you look at younger people, when they're going from lying to sitting, what we call supine to sitting, they don't use their arms. If you look at older people, people above the age of 70, when they're going from lying to sitting, they use their arms to do that. So if an older person has a shoulder fracture, has a rotator cuff tear, has arthritis of the wrist, elbow, or shoulder, they may find it difficult to get out of bed. So what do you do in those circumstances? Obviously, you try to work on the shoulder fracture and the arthritis and those things, but you do a very simple thing. You go to your surgical supply store, you go online, and you purchase a hand bed rail. It costs about $50. You slide it between the mattress and the box spring. Makes a huge difference in your ability to get in and out of bed should you have problems with one of your upper extremities. Getting up from a chair is extraordinarily important. Individuals in wheelchairs can live a very independent existence if they can get from that chair to a toilet by themselves, from that chair to another chair by themselves. So we use the word transferring when we're talking about getting in and out of a chair. So you may see some older people. I'm going to put the microphone down just for a second. I'll yell loudly. Okay? Now, you see someone getting in and out of bed. Call that a momentum transfer. And it tells us that that individual has some trouble with usually their lower extremities if they need to do that to get off a chair. Most of us get off a chair with a stabilizing, what's called a momentum technique. And what do we mean by that? Well, I'm sorry. This is the momentum technique there. Okay, so normally in a stabilizing technique, you simply move to the edge of the chair, you position your feet in the proper place, and then you use two muscle groups. You use your quadriceps muscle, and your quadriceps muscle is that thigh muscle which extends your knee. You use your gluteus maximus muscle to extend your hip, to go from a sitting to a standing position. I don't mean to be so anatomic here, but it's important to understand this when we try to fix problems if people are having this. So basically, you start sitting, you extend your knee, and you extend your hip in order to stand up, okay? Chairs are a big issue, and you're probably aware that there are some things you want to avoid in terms of chairs. You want to avoid sitting in the middle of a couch. You want to avoid low, heavily cushioned chairs, and you definitely want to avoid chairs on wheels, okay? So you want a solid chair. You want a chair with arms, and you want it to be roughly 20 inches high, because if it's too low, it's more difficult to get out of. You know that when you get up from a regular toilet, that can be problematic, so we have ways of dealing with that. But it's very important that you understand the difficulty you might be having if you're having trouble getting from a sitting to a standing position. So what are some of those things that are going to impair your ability to get off a chair? Weakness of what we call the proximal muscles, your quadriceps muscle and your gluteus maximus muscle. Those are the two muscles that extend your knee and extend your hip. Knee problems, huge issues in terms of getting off a chair. So knee immobility or pain can limit your ability to get off a chair. Hip disease can also affect your ability to get off a chair or toilet. And sometimes if you have low back pain or sciatica, that can affect it too, because when you straighten all the way up, that will sometimes exacerbate the symptoms you're having of your lower back or your sciatica, and that can also impair your ability to stand. So what do we do if we see somebody and we evaluate that person and determine that their trouble is with doing a transfer, that is sitting to standing? We try and decide what's the limiting factor. So if the limiting factor is quadriceps strength, we'll start quadriceps strengthening exercises, and one of your handouts gives you very simple quadriceps strengthening exercises. If you have hip disease, we might treat that with a steroid injection or surgery. Physical therapy actually doesn't help hip disease. Helps knee disease a lot, but it doesn't do much for hip disease. For knee disease, we have injections, physical therapy, and surgery. Balance exercises, we'll talk more about that when we talk about gait, and treatment of back pain and sciatica are all steps we can take if people have trouble with getting often on a chair. Huge issue as you get a bit older. I'm going to turn to Emily Dickinson now. I step from plank to plank, so slow and cautiously. The stars about my head I felt, about my feet the sea. I knew not but the next would be my final inch. This gave me that precarious gait some call experience. So we're going to talk about gait. It's a big issue. And I want to talk a little bit, again, can you all hear me as I'm moving along here? Okay. So we don't think an awful lot about how we walk, but I'm going to take a couple of minutes to go through sort of in slow motion what happens as you're walking. Now remember when you watch Olympic walking on the television, you notice the rules are you have to put your heels down first. And that's the way normal walking is. So normally when you walk, you put your heel down, you go into mid-phase and you push off on your left leg now. Your right leg, you have to bend your hip, you have to bend your knee, and you have to, what we call dorsiflex, or pick up your foot to get your right leg from behind you to in front of you. So if you can't bend your knee, you have to swing your leg out. We call this circumducting your hip. If somebody can't bend the knee, they have to walk like this. If they can't pick up or dorsiflex their foot, they will hyperflex their hip, and they'll have what's called the steppage gait. They'll walk like that, all right? So as you see people walk, it's what we call heel, mid-phase, push-off. And here you're in what's called stance phase. So you're bearing your weight on your left leg. You shift your weight to the left side. You flex your hip, flex your knee, and dorsiflex your foot. Swing your right leg out. Put your heel down here. Shift your weight over to the right side. Follow through and continue to do that on a continuous basis. And with normal walking, you should be walking with a gait from about 2 to 3 inches wide. The length of your foot's about 15 inches on the length of your stride. And you should be walking with your hands moving and not looking down. And your body should be kept fairly stable as you're walking. So here, if I have a pointer here. So here's heel down, mid-phase, push off, bending the knee, and picking up the foot. Very, very important. So this is a normal gait, and it's important to teach clinicians about a normal gait so they can identify when there are problems affecting your gait. So some of the common problems that affect your gait, again, I pointed out already, a normal stride is 2 to 3 inches wide and 15 inches long, a normal step. As we're watching somebody walk, we want to see if they leave their foot flat on the ground for as long as possible. Do they walk in a relative straight line or shift from side to side? Do they lean towards one side when walking? Do they look at the ground when they're walking? If people don't feel their feet very often, have nerve disease in their feet, they'll very often have what's called a searching gait. Look at the ground and search as they walk. A very common gait pattern in older people, particularly with cognitive problems, is a so-called cautious gait, or gait with fear when falling. So I mentioned a little bit earlier that normally you have about half the time when you're walking, you're in what's called stance phase, and about 40% of the time you're in what's called swing phase. So your right foot is moving up, and we call that swing phase. If you're very, very afraid of falling, you don't want to be in swing phase, so you'll do the following. Now, living in New England and living through winters like we just left to get down here, we're very used to have a driveway which is covered with ice, okay? So when you step on a driveway covered with ice, you usually do the following. You put your feet wide apart, you dump down a little bit, and you walk like this. You don't pick up your feet, as your mother would say, okay? But that's a cautious gait pattern. So a cautious gait pattern, people don't want to be in swing phase. They want their feet to be on the ground all the time. So they'll walk like this. So that's a fear of falling or a cautious gait type of pattern that we frequently see. What are other things that will happen? I've already mentioned this. If I can't bend my knee, then I'll circumduct my hip like this, okay? If I can't pick up my foot, I will have what's called a steppage gait, the guards at Buckingham Palace, the hyperflexion of the hip. If I'm watching the Patriots game last night and I had a few too many beers, my gout might be acting up. So I may come in and walk like this. So what I'm doing now is I'm spending less time on one leg than I am on the other. I'm spending less time on my left leg than I am on my right leg. If I want to charge you a large consultation fee, I'll call that an antalgic gait. If I want to communicate with you, I'll call it a limp. And it's all the same thing, okay? But it's an important thing to recognize that because, in fact, if I have a bad hip, my left hip's a problem, I may do okay walking. And when I turn, if I turn to the right, I'm turning on my good hip, I'm fine, okay? But now, if I'm trying to do the same thing, if I'm walking and I want to turn on my left hip, I'm now bearing all my weight on my painful limb, and it's a good way of falling, okay? Is trying to turn on a painful leg. So we do worry about people that limp, and we'll give them, number one, we'll try to find out what's causing it, and we'll try to deal with that, and then we'll try to deal, if we can't fix it, we may deal with an assistive device like a cane, or we may use other things to deal with that. So this is a person can't pick up their foot, they'll have what's called a steppage gait. And if they have a painful leg, they'll be spending less time on that leg, and so they'll call it a limp. this is a circumducted gait because somebody can't bend their knee, okay? So, but the key step in walking, the key issue in walking is balance. So when we want to assess balance, nowadays I use a very simple test. It's called a 4-stage balance test. So the 4 stages are, I'll have the patient stand with both feet together without an assistive device, and I'll do that for 10 seconds. Then I'll have the patient take their right toe, big toe, put it on the instep of their left foot, and do that for 10 seconds. If they can do that, I'll have them do a so-called tandem gait, which is one foot in front of the other, do that for 10 seconds. If they can do that, I'll have them stand on one foot for 10 seconds. So those are the 4-step balance tests. We stop the test when someone's having trouble. We're standing right next to the person to make sure they don't fall over. And patients who can't hold a tandem stance for 10 seconds have increased fall risk. But it's a very easy way of identifying central balance problems in people who are having trouble falling. It's a simple test to do. Again, foot together, toe on and to the instep of one foot in front of the other, and standing on one foot. If we have patients who have major balance problems, we have a variety of things we'll do. Mainly exercises. Tai Chi is terrific. I'm going to talk about the kitchen exercise in a minute. Building up endurance by walking or swimming. Bracing is, if needed, and appropriate help with a cane or a walker as needed. All right? And balance training is best if it's done regularly. It's progressive, and it's at least not too boring. It doesn't have to necessarily be fun, but not too boring. So in your handouts, I've given you a few of the balance exercises that Mary developed with Maggie Gottschalk. You need a very fancy, very expensive piece of equipment for this. You need a kitchen sink. And if you have a counter on the kitchen sink, that's perfect. Because the way to do these exercises is put your hand on the sink so you can't fall when you do them. And then you do the exercises. 5 steps to the left, 5 steps to the right, standing with one leg, a variety of different approaches. But the major thing is you're doing it, putting your hands on the kitchen counter so you're not going to fall. Oops. All right. So lastly, very briefly, I'll talk about stairs. So the problem with going upstairs is when you have hip disease or ankle disease. Because when you're going upstairs, you're flexing your hip, and you have to dorsiflex your foot to clear the step. When you're going downstairs, you are bearing weight on a bent knee, and that puts a lot of strain on the knee, particularly the so-called patellofemoral, that's between the kneecap and the knee bone, part of the knee joint. So going upstairs, we worry about hip disease. Going downstairs, it's more apt to be knee disease that's going to give you trouble. And going downstairs is a problem. About 75% of falls on stairs occur when people are going downstairs, particularly when they're holding objects in their hands. Bifocal lenses can be a problem because it's hard to identify how far the step is from your foot when you have bifocal or trifocal lenses. And also, if you have nerve damage to your legs, like patients with diabetes often have, you have trouble sensing where your foot is, and that can also increase your problems. So we teach people, if the laundry's in the basement, to put the laundry in a plastic bag and throw it down the stairs. Don't walk down the stairs holding a laundry basket, because that's a recipe for disaster. So what's our next step here? We want to continue Yale's groundbreaking research in preventing falls. We're in the process of developing a mobility center. We're trying to train clinicians in the skills needed to assess and treat mobility problems. And this is all about low-tech work. You don't need MRI machines. You don't need ultrasound. You need to observe the patient. You need to watch the patient going through each step and determine what is that factor that's limiting this person, where they're getting out of bed, getting off a chair, walking, etc. You need to determine the cause of that. Is that a knee problem or a hip problem or a back problem? And then design a plan to treat that immobility and to restore independence. Thank you. I'm going to turn things over to Brienne now.
Okay, so as Raj mentioned before, I have done training in internal medicine, in geriatrics, and in sleep medicine, and so I'm going to talk to you about my passion today, which is where these two fields meet. And so I want to start with a little patient participation, and I want to ask you to raise your hand if you care about sleep. Is sleep important to you? Oh, okay, wonderful. All right. I think it's potentially one of the most important things, but I'm a little bit biased. So here's what I want to talk about today. I hope to help you answer these 3 questions by the end. What is normal when it comes to sleep? When should you talk to your doctor? And what can you do to improve your sleep? And so in the bottom corner here, I have a picture that I snapped when I was in Orlando at Disney World a few months ago. How to sleep. This is the noted lecturer, educator, and somnambulist Goofy. It says, guaranteed by the time this lecture is over, you'll be fast asleep. So my one goal, probably before answering any of these questions for you, is that you all are not fast asleep by the end of this. Okay, so let's get started with what's normal. This is the National Sleep Foundation's recommendations about sleep duration. And so at the very end here, where's this pointer? Over here, we have adults. And what you might notice here is that young, middle-aged, older adult, the sleep recommendations are actually the same. The recommendation is 7 to 8 hours. And where does that number come from? Well, it comes from studies that have shown that older adults who sleep 7 to 8 hours have better cognition, better physical and mental health, and report a better quality of life. And so I think what I want to dispel is that myth that as you get older, you don't need as much sleep, because that's not actually true. So again, keeping with that theme of what's normal, this is very well known to a sleep physician. This is a sleep histogram. So along the bottom, you see the hours of sleep during the night. And on the side, we have stages of sleep. So up here, you're going to start, you're awake, that's W, and then you're going to go through more deeper stages of sleep. And in the beginning, what you might notice here is that this is where your deep sleep happens. It's really in the beginning of the night. And after about 90 minutes, you'll cycle up into your first REM period. REM is rapid eye movement sleep. That's your dream sleep. REM usually ends with an arousal that you may or may not remember. And then you'll do it again. You'll cycle through these stages of sleep. Towards the end of the night, it's really more lighter stages, cycling with REM. And so, again, the 2 things I want to focus on here are deeper, more restorative sleep happens in the beginning of the night. And then the other thing is that arousals are normal. Okay, so as long as they're brief and you can go back to sleep, that's not a problem. We expect that. But sleep quality may change. And what I mean by that is, as we get older, we do have less deep sleep. So arousals are more common. So your sleep quality may change, but as I reviewed for you in terms of sleep duration, your sleep need does not change. All right, so on the subject again of what's normal, I want to talk about how the timing of sleep changes with age. So here we have a time, again, we're sort of looking through the night. And over here we have melatonin level. So melatonin is a hormone your body makes naturally and releases in the early evening. And it's a hormone that tells your body it's time to go to sleep. So in blue here, we have usual sleep phase. And so these, if you have a usual sleep phase around 8 o'clock, your melatonin increases. So maybe around 10 or 11, you're ready for sleep. But we know with age, you tend to have an earlier release of melatonin. And so what that means is you'll go to bed earlier, and you will also wake up earlier. An early morning awakening may be bothersome. Having to go to bed earlier may be bothersome. Maybe you have to miss out on certain activities, but it's not abnormal as long as you have a normal sleep duration. Okay, so when should you talk to your doctor? And I think the important takeaway point here is if you have sleep disturbance that you feel is impacting your daytime function. But more specifically, if you have snoring or pauses in your breathing that you might notice or perhaps your bed partner notices, that can be a sign of sleep apnea, which is a primary sleep disorder. I'll talk a little bit more about on the next slide. If you have frequent urination at night, and so my rule of thumb is urinating 1 to 2 times a night is most likely to be normal. But if you're urinating more than 3 or 4 times a night, that can actually be a sign of sleep apnea, and it's something you want to speak with your physician about. Leg discomfort. So this might be numbness, tingling, a creepy crawly sensation that prevents sleep. That can indicate another sleep disorder, which is called restless leg syndrome, and you want to speak with your physician about that. Acting out dreams. This might be something that you have noted or remember, or it might be something that a bed partner has told you about. This is an indicator of a primary sleep disorder called REM behavior disorder, and it's something you want to talk to your physician about. And finally, anxiety, rumination, mind racing that prevents sleep is something you should speak with a physician about. And so all of these symptoms may indicate what we call a primary sleep disorder. And these are the 4 major sleep disorders. Obstructive sleep apnea, Dr. Cooney referred to when he was talking about CPAP. Restless leg syndrome, rapid eye movement behavior disorder, that's the acting out dreams. And insomnia, so trouble falling asleep or trouble staying asleep with mind racing, anxiety, etc. All of these things become more common as we age, and all of these things are things that we can fix. So, what are the problems with sleeping pills? You are here with a panel of geriatricians, and you're going to hear more in the next talk about the 4 M's. 2 of those big M's are mentation, or your mind, your ability to think clearly, and mobility. And of course, Dr. Cooney just told you a lot about mobility. Well, we know that sleeping pills interfere with those M's. And so more specifically, and when I talk about sleeping pills, sometimes we call these the Z drugs, so Zolpidem or Zaleplon, you might know them as Ambien or Lunesta, and sometimes benzodiazepines like Valium or Ativan might be used for sleep. Why we don't like them? They are associated with an increased risk of falls, and then of course related to that, hip fracture. So there goes your mobility. They are associated with increased driving accidents. Use of these medications also impair your ability to think clearly. So we know they increase risk of cognitive impairment. And a big one, actually, that people often use to help them sleep is a medication, Benadryl. I'm sure you're all familiar with that. The reason we don't like Benadryl is because it actually is anticholinergic, which is a fancy way of saying it impairs your ability to think clearly. And finally, all of these medications have been shown in multiple studies to increase risk of death. And so you can see this cartoon here, this older fly is talking to the Grim Reaper fly and saying, oh well, I've lived a good long life of over 29 days. So we know there's a huge risk of death with these medications. Okay, so you can't take those medications, but what can you do? And so I've talked a little bit already about primary sleep disorders, but really what I like to focus on and sort of the conceptual framework of my work is talking about what about these things? These medication effects, this is another M you're going to hear about in the next talk, and behavioral factors. How can we think about these in older adults and intervene on these things to help with sleep? And so I would be remiss if I didn't mention Mary Tinetti in my own work. She's been a very important mentor, and really this framework comes out of the groundbreaking work she's done with falls and dizziness. So I'm borrowing from her. Okay, so I have done work specifically on insomnia and found in older people these specific things that all independently increase your risk of having insomnia. Depression. These are those primary sleep disorders I was talking about. Certain medications. Too much sleeping during the day. Many of these are things we can fix. Similarly, I've looked at the symptom of daytime sleepiness and found, again, multiple factors independently associated with this. Low physical activity, depression, sleep apnea, medications, and inability, difficulty sleeping at night. Again, these are all things that we can fix. They're all potentially modifiable. And so that's what my work focuses on. Medication effects. This is something I actually put in the handout for all of you, so I just want to highlight a few. The fact is medications can affect your sleep in many different ways. And so to highlight a few, daytime drowsiness, I already spoke about Benadryl. It impairs your ability to think, but it also makes you drowsy during the day, which can make it hard to sleep at night. Benzos, I mentioned, Valium, Ativan, can make you sleepy during the day. Certain medications might be activating, which might make it hard to sleep at night. And then, interestingly, there are certain medications you might be taking that can worsen or cause primary sleep disorders, like restless leg syndrome or REM behavior disorder. And finally, you might be taking a medication that's causing a sleep disruptive symptom. The most common example I think of is there are certain medications that cause cough. And if you're coughing at night, it's pretty hard to sleep. You're on a medication like a water pill, and you have to urinate multiple times a night. That makes it hard to sleep. So that's another way that medications can affect your sleep. All right, Zeitgebers. Does anybody speak German here? No? Okay. Oh, do you know what this means? Time. All right, so Zeitgeber is sort of literally time grabber. So I'm going to teach you now about cues that you have in your everyday life that help you maintain a normal sleep-wake cycle. The first and most important Zeitgeber is light. You go out in the morning, the light hits your eye. It goes to this master clock in your brain, and that master clock sets off a bunch of physiologic signals that tell your body it's time to be awake and alert. And then, at the appropriate time, that it's now time to go to sleep. But we also know that there are so-called non-photic, non-light-related time grabbers, and these are things like having a normal sleep-wake cycle, physical activity, social time, and meals. These are all cues you can give your body to maintain a normal sleep-wake cycle. Sleep hygiene. Again, this is in your handout. I'm going to highlight a few things here, but these are behaviors that you can do to improve your sleep. So, number one here, avoid caffeine, nicotine, and alcohol. So caffeine and nicotine can be very activating. They can make it hard to fall asleep or stay asleep. And alcohol, people often think of as a good way to self-medicate. And the fact is, it can help you fall asleep, but as your body starts to metabolize the alcohol, it will wake you up. So you may fall asleep, but you will not stay asleep. So that's why we recommend avoiding it. No naps, or, this is my sort of addition, brief and early. So brief means less than an hour, and early means that you have to avoid napping in something that we call in the sleep world the forbidden zone. The forbidden zone is 7 to 10 p.m. You're watching TV, you're on your couch, maybe you doze off. That's not allowed, because then it makes it very hard for you to go and fall asleep in your bed. So no, if you're going to nap, it's got to be brief, and it has to be outside of the forbidden zone. And then finally, stay active even if you feel tired. Many people might think, I didn't sleep well, so I'm not going to go do that thing today. I'm not going to go play golf. I'm not going to go to the theater. I'm not going to go see my friends. That's the wrong reaction, because if you go and do that activity, you're more likely to fall asleep at the appropriate time afterwards, and that helps you maintain a normal sleep-wake schedule. And so I think this is one of my final slides, but cognitive behavioral therapy for insomnia is something many people don't know about, and this is sort of the ultimate behavioral therapy to improve your sleep, and I want to make sure you all know about it. It's a non-drug-based method. So as geriatricians, we like this. We like to avoid medications if we can. And we focus on changing behaviors that might have a negative impact on your sleep, or changing misconceptions or negative thoughts about your sleep. This is highly successful. It has been studied specifically in older adults and been shown to be highly successful. As I said, it's not a medication, and believe it or not, this is the first-line therapy above any sleeping pill. This is the first-line therapy for problems with insomnia or problems initiating or maintaining sleep. So in my final slide, I'll talk about my next steps. I think, Dr. Cooney has mentioned he wants a center for mobility, and my ultimate goal is to really have a model that is specific for aging and sleep problems, to say what is it that's different and unique about older adults that we should be considering when we think about sleep problems, but also what are those things that we can change, and I've tried to highlight a few of those for you today. And so what does it mean for me? Well, it means I have to spend a lot of my time building the evidence, getting grants, and designing these interventions, but it's certainly a place where I would love your input, because ultimately this is for you, and I need to know whether you all find these sorts of things helpful. So those are my next steps in terms of trying to help with sleep-wake symptoms in older adults. All right.
Hello, James Lai. It's great to be here, and my job here is, unlike last night, is not to go into overtime and to finish up and make sure that take these three wonderful talks that we've already heard and try to demonstrate how we can translate this into actually improving patient care, directly improving patient care. And I think one way we're going to learn about how we can do this is through an age-friendly health system, which affects how doctors, nurses, and clinicians can deliver care. So in the next 12 minutes, I'm hoping to answer three questions. What is an age-friendly health system? Why do we need one? And how will it affect your care as a patient? So what is an age-friendly health system? Has anyone in the room ever heard of an age-friendly health system? Okay, all right. Well, an age-friendly health system is evidence-based care in 4 core health areas, which I think you already know what they are, and it's applied across all settings of healthcare. So what I'm talking about is not just internal medicine or family practice offices. I'm talking about surgical offices, inpatient medicine, ICUs, skilled nursing facilities, all settings of healthcare. And the framework we're using for the age-friendly health system is called the 4M model. And it's 4 things. It's what matters most, which we've heard a little bit about, developing patient priorities and learning about what matters most to patients. Mobility, it's screening for falls and physical functioning in older adults to make sure that they're still able to do what matters most to them. It's medications. Screening for high-risk medications, eliminating medications that we don't need or don't want, and if we do need medications, focusing on the ones that are the safest ones that we accept. And lastly is mentation. That's the 4th M. This is screening for things like depression, dementia, changes in your ability, your memory, and importantly, delirium, this waxing and waning state of mental confusion that we see very frequently in the hospital and in the setting of acute medical illnesses. This is very important in the sense that it's a huge barrier to patients figuring out what they want and their priorities. It's a risk for falls, and it's a cause for why many medications are given. So the 4 M's, there's a 5th M, which is multimorbidity or complex multimorbidity care, which is multiple medical conditions, which I won't talk about. But the 4 M's were not, these are not arbitrary at all. In fact, they were very calculated and developed through a long history of data and experience, and much of the research performed to develop these 4 M's was performed at Yale University and within the section of geriatrics at Yale. So the first one, what matters most, is what Dr. Cooney has already spoken about, and it's the work of Mary Tinetti, which we know that following through on patient priorities lowers hospitalization and increases satisfaction for patients. We know that using fewer medications and safer medications prevents complications. Also, through Dr. Tonetti's work, we know that maintaining function reduces falls and reduces time in the hospital. I don't think anybody wants to spend any more time in the hospital than they need to. Lastly, also through the work at Yale, through Sharon Enaway at Yale University, we know that identifying and managing mood and memory problems prevents confusion and complications. Again, the same complications we've been hammering home today, which is falls, loss of mobility, and hospitalization. So the age-friendly health system, it's a national initiative. Currently, right now, there's interventions in the 4 M's occurring at 127 sites across the country. So it's a big deal. Dr. Tonetti is actually co-chair of the advisory committee for the national project. And as you can see on this slide, we have key foundations and organizations devoted to innovative healthcare changes who are supporting the project and providing important leadership and administrative support to make sure that ensures the success of the program. So let's move on to Connecticut. We've got the Yale New Haven Health System, which maybe some of you in the room are familiar with. I think the take-home point here is it's big. It's very big. We have over 2,500 licensed beds in the state, and we do over 2.3 million outpatient encounters. We've got more than 24,000 employees. So what you need to take away from this is that any intervention like the 4 M's with the age-friendly health system has the potential to have huge impact across even just the state of Connecticut. Let's take a look at Florida. We have 2 sites in Florida, Moffitt Cancer Center in Tampa and University of Florida Health System in Gainesville. Each of these has a few sites at them, but in general, you can see there's a little work to be done in South Florida. So I think we'll talk a little bit. We'll have some time afterwards to talk a little bit about how we can do this. But I think it's something where there's an area of growth here. So why do we need an age-friendly health system? So I think there's 2 main reasons. The first reason is, again, patients are more complex. This slide shows the percent of patients with more than 6 diagnoses, just like our Mr. Smith. And on the bottom here, you see that when you compare the number of diagnoses with age increasing from 65 to more than 85, you see that the percent of patients with more than 6 diagnoses rapidly increases. So this means greater need for talking about patient priorities with competing diagnoses, more medications, focusing on mobility with an increasing number of diagnoses. The second reason is healthcare use increases with age. Now, we all know the population above the age of 65 is increasing. It's 55 million now. It's going to continue to grow. The implication of this, though, is that we're going to use more care. And this slide demonstrates that, particularly with ED visits. With ED visits and hospital days, you can see that from age 65 to greater than 75, the rate of use of health care increases, it almost doubles. So you're going to see a rapid increase as folks get older. So how will the age-friendly health system affect your care? I think it's time we went back to the case of Mr. Smith that we heard about a little bit earlier. and go through what might happen to him. So let's say Mr. Smith came to the Yale emergency department after a fall at home and recently had a feeling of heart fluttering while he's exercising at the club gym. You can see he's got at least six diagnoses, including high blood pressure, arthritis, and diabetes. And he's on several medications, one or two of which you might recognize as being fairly high risk. So Mr. Smith gets to the emergency department, and you see that he's got a low blood pressure here and a fast pulse. The doctor is concerned about an abnormal heart rhythm and wants to admit the patient to the hospital for monitoring. Somewhat concerned that the patient may actually have to have an invasive heart procedure, possibly. This is a great opportunity to explore patient priorities. This is where we can teach physicians to ask the right kinds of questions to guide their care. For example, have you talked with your primary care doctor about what matters most to you? I understand that you wouldn't want surgery. Mr. Smith didn't really want his hip surgery. But would that change if this would help you get back to the gym? So it's asking these kinds of questions that focuses the care in the hospital towards what Mr. Smith would want and may ultimately affect whether he gets a procedure or not. And doing this at the beginning of the admission makes a big difference. So now Mr. Smith heads up to the floor in the hospital. This is actually Yale New Haven Hospital ED. So he arrives on the unit, and we screen him for delirium, which is that waxing and waning state of mental confusion. The nurse will evaluate him with a 2-item screen for delirium, asking him, what are the months of the year backwards? What is the day of the week? If you're confused, this can be pretty tough questions. If he answers these incorrectly and the screen is positive, this will trigger a delirium treatment protocol. And as you can see here, this is an active area of what we're doing with the age-friendly health system. We're developing delirium treatment protocols, and this is just an example of the kinds of things we'll do. But I think to give you a sense of the kinds of interventions that we're looking at, we'll look at doing things like managing his sleep, clustering care during his sleep hours, making sure it's quiet, because we know those kinds of things can disrupt sleep and lead to further delirium. We'll look for pain, look for dehydration, look for underlying sources of infection, and check blood sugars. All these kinds of things that will lead to underlying delirium. And lastly, even though a patient may be delirious or have some confusion, it's still important to get these patients up and moving to make sure that they do not lose their mobility. Next, the doctor on the floor will actually screen Mr. Smith for high-risk medications, okay? So for Mr. Smith, in this case, he's taken some Benadryl over the counter, which we all know, actually, hopefully everybody knows in this room when we walk out of here that Benadryl is not a medication we like very much. It's an anticholinergic medication. It's been well shown to be associated with confusion and falls. So we'll inform Mr. Smith that this is not a medication we want him to use and get him off it. Now we have losartan, which is a nice blood pressure medication, but his blood pressure was low. And it may be very well justified for his high blood pressure. Sometimes the risks of medications outweigh the benefits, and this is just one of those situations. So he may end up actually having to stop this medication, even though it's something that one of his doctors may told him is good for him. So I think this is one other. So what I also want to show you is that behind the scenes, there's a lot of work that goes into this. So one of the things the age-friendly health system is doing is helping us develop ways to track, tools to track and monitor high-risk medications. And this can involve a lot of computer work, a lot of boring computer work. But what happens is we develop filters in our electronic medical record system that actually flag high-risk medications to anybody working in the chart, so that when someone looks in the chart and sees, hey, they're on a medication they shouldn't be on, or it's a high-risk medication, we know it's there and we can address it. So you may not see these things as a patient, but it's important to know that they're going on in the back room. Lastly, on the unit, it's important to keep Mr. Smith moving, okay? As Dr. Cooney talked about, we're going to screen for fall risk. We're going to do clinical assessments to look for balance and walking. We'll also use things like the Johns Hopkins highest level of mobility scale and other scales to help track mobility while the patient's in the hospital, while Mr. Smith's in the hospital, and make sure that he reaches certain goals and gets back to the level of mobility that he had before he came in. So I think there are three things I just want to summarize at the end here. Age-friendly health system is an evidence-based care model for older adults that focuses on what matters most. Secondly, Yale Geriatrics is a leader in developing and implementing an age-friendly health system, and we will continue to be. And finally, I think you should demand that your health system become age-friendly and become a part of this demonstration project and program to help improve the care of older adults. So, thank you very much.
Thank you. That was outstanding and really wonderful to have some very, very distinguished panelists here discussing the science of aging. I'd like to open the floor for questions, and we'll move the microphone around if so be, so you can, so our panelists can hear a question. Oh, you got one? Okay, perfect. Lead this gentleman here. Another one back there as well.
Me to go? I can go. Just one question. Among the many things you mentioned, I did not hear any mention whatsoever about nutrition and its role in good health for people as they age, and I'd like to hear your thoughts about that.
We all had about 10 minutes apiece, so we couldn't cover all aspects. One of the most important aspects of nutrition is its predictor of mortality. So when you're doing goals of care discussions with elderly, particularly with family members or with older patients, the three major predictors of mortality are poor nutrition, poor cognition, and poor function. So weight loss, a 10-pound weight loss in 6 months clearly is associated with increased mortality. So we agree that nutrition is very, very important. We had a lot to cover and couldn't go through all the other things.
Yes, sir.
Does taking a melatonin pill suppress your natural body's production of melatonin? And what do you think about the use of melatonin?
So that feels like a question that's meant for me. So this is a subject I could talk a lot about. Does it suppress your natural melatonin release? It can. And in fact, sometimes we do that intentionally. I talked about advanced sleep phase, and so if we wanted to try and change your sleep phase, we could do that with melatonin. If you experience jet lag, you can use melatonin to actually change your sleep-wake rhythm. So yes, melatonin can change that. How do I feel about melatonin? Well, it's certainly a pretty safe medication, especially in low doses. I think the one thing I warn against is to keep going up and up and up on the dose to try and see if there's a response. At higher doses, it can have side effects. Particularly, I think there's good evidence to show that it can mess with your blood sugar. So if you're going to use it, there's really, outside of REM sleep behavior disorder, which we use melatonin for, if you're trying to use it for sleep, it's pretty safe as long as you maintain it at doses below 6 milligrams. Did I answer all your questions? Do I recommend it? Yes, I think melatonin is definitely one of the safest sleep medications that you can take. But what I worry about is if you are feeling the need to take it on a regular basis, that maybe there are some other things about your sleep we should address.
If I can make one other comment too, is when you're taking a sleep medicine every day, it doesn't work. So the problem with taking it every single day is it's not very effective, whatever that medicine is, even melatonin.
Thank you, panelists. I learned a lot. I liked what you all said about collaboration. I think that's very important, especially about my medications. Now, who is going to pay for my cardiologist to talk to my GP? How is that going to work into the insurance system?
Yeah. We have to take American medicine into the 21st century. It's about the 18th right now. And that we have to integrate things much better. A lot of systems are being developed with better integration. We actually we're starting to do something at Yale, which I think other people are doing as well, and what's called an e-consult. And Medicare will actually pay for that. So your primary care physician can contact your cardiologist about the use of, about your medications, get a consult again via email or via electronically, and Medicare will actually pay for that. So there are some bright lights on the horizon, but we're still a long way from a fully integrated health system.
Yes. I just had one more comment on that. You know, one of the things that's changed over the last 5 years is really electronic medical records. And it's improved the communication between doctors and between doctors, nurses, nurse practitioners, especially specialists and primary care doctors, and the hospital as well. There's one med list a lot of times, so that actually really helps a lot. We can all reconcile the same med list, and so technology plays a big role in this.
One of your slides showed that in the state of Florida, there's only 2 centers that are age-friendly, both of which have medical schools. Do we need a medical school in Naples?
So it's a loaded question.
Maybe. No, I think this is not something that's going to go away. There's many other states that don't have kind of folks working on age-friendly health system projects. I actually think that it will get to South Florida no problem, even without a medical school, because I think the kinds of interventions that are being introduced through this project are cost-effective and good for patient care. And when you hear those things, it will spread fast. So I think it'll happen. It's just going to take some time.
Yes.
It clearly is. Take all the Benadryl, all the Tylenol PM in your house and throw it out. When you take medications for dementia, you use what's called a cholinesterase inhibitor, Aricept, Exelon patch, etc. And Benadryl does just the opposite. So I'm
talking about Benadryl as a sleep aid.
It's a terrible sleep aid. All right. It took us about 10 years to get it off the formulary at Yale New Haven Hospital, so it's no longer used for sleep at Yale New Haven Hospital. It's really problematic because it causes what's called delirium or confusion if you have any minor cognitive problems. So it also affects your urinating. It just has a lot of bad side effects. So actually, we recommend all the patients that come to our clinic don't take allergy pills unless you really have to. Don't take any over-the-counter sleep pills because most of them have Benadryl in them. And don't take cold pills. They don't work anyway. So it's really a bad drug for older people.
The Benadryl in my house works pretty good for sleep.
I'm not saying there's an exception to every rule, and I'm not saying universally it kills people. But when you study the medication, its bad effects greatly overwhelm its good effects.
Yes, sir.
I'd like to oppose on you for two questions. First of all, I find a lot of times in the mornings, if I'm at my desk, I get so sleepy that I'm not very productive. Usually then, after that, I'll take a nap. Now, is that a decent solution? Is that okay?
So napping is one of the things about sleep medicine that's actually being very actively studied. And if I were to summarize it, I think what we know so far is that napping does have a lot of benefits for your cognition and for your ability to think clearly. And it's okay as long as you're getting a relatively normal amount of sleep at night. So when we are worried about napping is if it's part of a cycle of sleeping too much, because we know that's bad for you. But if you have a relatively normal amount of sleep at night and you're taking short naps that don't otherwise interfere with that sleep, then it's fine.
Thank you. My second question. I have restless leg syndrome. How far ahead of my bedtime should I take the medicine for restless leg?
So you should probably take it, if you can determine the time the symptoms usually come on, then you want to take the medication about an hour before that. So if you know your symptoms, sometimes people find them in the early evening. That's most common. So if you know your symptoms come on around 7 o'clock at night, then you want to take the medication at 6.
Thank you.
One other question. We can't answer individual health questions. We don't know your health. So we can answer general questions, but if you ask me why your back hurts, I'm not going to do a very good job of answering that, all right?
Yes, I have a question for Dr. Cooney. Could you talk a little bit about clinical mobility assessment? You know, is it your hips? Is it your knee? Is it your back? And what do you do when the specialist, meaning the orthopedist, the neurosurgeon, the neurologist, and the pain management specialist can't agree on what's driving what?
Yeah, it's a little bit hard to say because there's not a well-defined specialty of looking at that. Probably if I was going to pick a specialist, I might pick an arthritis doctor, a rheumatologist, which I happen to be, but also specialists in rehabilitation. That is physical medicine rehabilitation, sometimes called physiatrists. First of all, they don't have a dog in the race, so they're not pushing their particular procedure. But I've spent a long time working with multiple specialists, and it's the best thing to do is when we decide you need a hip replacement, then we send you to the orthopedic surgeon. We don't send you to the orthopedic surgeon because you're having trouble walking. We have to figure out what it is. It's not very complicated. It just requires your powers of observation. It's absolutely key. And sometimes physical therapists are very good at that. So I would say probably the three that I would look at would be physical therapists or occupational therapists, specialists in rehabilitation medicine, physiatrists, and arthritis doctors. Probably have the best broad spectrum of looking at that. Now you'll find the odd orthopedic surgeon who's fabulous at it. So I'm not saying that, but it's a tough call.
Yes, I've had the... Is this working? Okay. I've had the distinct privilege of spending my entire career in internal medicine and tertiary care hospitals, including Grace New Haven, Yale University Hospital, Southwestern Medical School in Dallas, and Vanderbilt University. We had a tradition that I loved. We had all orders and every decision going through one person in the hospital. That was the intern. Now, it's true that the intern didn't know as much maybe as this consulting physician or that consulting physician, but it surely was a great training experience for that intern. But also, it kept track of the complexity of the patients that often occur on those wards. Oftentimes our patients would be like your elderly patient. I'm wondering if you've done a research project that would possibly have a similarity. And because the elderly people have oftentimes many conditions, and it would be so fascinating to me if
so if I can just try to answer that.
If this analogy...
Right. There have been enormous numbers of studies that have looked at healthcare systems. By far, the best systems have strong primary care bases. So the individual that should be making final decisions should be your primary care physician. Unfortunately, that doesn't work all that well. It takes a lot of work to do that. But if you go both inside this United States and throughout the world, the strongest, most effective systems have strong primary care bases. Next question, sorry.
Thank you. Dr. Lay, you are encouraging us to advocate for ourselves, essentially, to encourage our doctors or choose a doctor who is in favor of this age-friendly approach. At what age do you think we should encourage our doctors to assess these different levels of, do we wait until we're limping, or do we establish a baseline for our mobility, are we feeling blue or low, or all the different aspects of the four major aspects, to set a baseline, or do we just, so that we don't have to wait until we're pulling up lame, let's say?
That's a great question, and I think that's a point well made. Is that these kinds of interventions, they're good for all patients. I mean, they're not just they're particularly good for older patients, and they've been studied in that age group. But they're actually good interventions for all patients. So it's actually not too early to start evaluating folks even in late 40s, 50s. I mean, these are things that physicians should be aware of and screening for all along. They become more relevant as you get into your early 60s, 70s. So I think anything to add with that?
Yeah, I'd just say in our system, again, what's called Northeast Medical Group, which is a foundation that's run by our health system, we've actually made the recommendations that cognitive testing, very simple cognitive testing, a 2-minute test, should be done with everybody 65 and older. We also ask physicians to assess, and this is just questions, one's ability to do what we call activities of daily living. That's getting out of bed by yourself, walking by yourself, using a toilet by yourself. We suggest that be done on everybody 65 and older. And we suggest a medication review every year on people 65 and older. So that's what we're doing in our system. It's not very time consuming. It gives us a good baseline. And it's very important to identify cognitive problems, because if you're giving someone 12 medications and they have cognitive problems, you have a major issue in your side. Right down here, everybody.
Dr. Miner, I was wondering if there's such a thing as substitutes for sleep, because having a lot of problems that cause me to not be able to get very much sleep, I'm finding that with art therapy, flower photography in particular, if I'm working with that, which is something that I love, that causes me to be very happy, that I find that gives me almost a substitute for sleep, that I revive and feel that it keeps me going when I don't get very much sleep at all.
Well, I don't know that it's a substitute for sleep, but what we know is that mood and sleep are so tightly intertwined. So people who have trouble sleeping are more likely to have mood problems. People who have mood problems are more likely to have sleep problems. So I think it's absolutely true that if you are treating one of those things, you're likely to see benefits in the other domain. And cognitive behavioral therapy that I mentioned for insomnia, people are looking at that and looking at outcomes for depression and finding out that people who do cognitive behavioral therapy for insomnia do have improvements in their mood. So I think your point is well taken in that those substitutes, as you call them, it's often something that we try to act on if we are concerned about sleep problems.
I want to ask a slightly different question because Dr. Contreras, who's one of the practicing physicians in the practice here at Morens Park, is with us today. And I'm just anxious to hear what his reaction to what he's heard today is. And I'm going to hand him the mic. Do you dare answer that?
Thank you for putting me on the spot like this. With regards to the question that was just asked, Medicare pays for an annual wellness visit. That started at the age of 65. And the annual wellness visit was designed with the help of geriatricians and other primary care physicians to identify some of the issues that were raised today very eloquently. And this is paid for by Medicare. We encourage everybody, starting at 65, to get an annual wellness visit. Primary care doctors know about it. It's a little bit challenging to administer because it involves some screenings, cognition screenings, gait screenings, nutrition, and all the things that were covered here today should be done annually, starting at age 65, because that's when you want to try to pick up issues. And if it's done every year, that's a good way to check for changes that may be taking place over time to identify these interventions that are so important to prevent progression. So I just wanted to reiterate, everything that's been spoken of. We encourage all of our patients here to have an annual wellness visit. We usually do that in conjunction with the so-called physical. The annual wellness visit is not a physical. The Medicare does not pay for physicals, but it will pay for this annual wellness visit. But we generally combine the visits together to identify that. That way we can keep a record and identify people who are changing in progress.
I have a pretty loud voice. I think I could handle it without the mic. Dr. Miner, if you ever get on a CPAP machine, can you ever get off?
That is a good question. I think, in short, most of the time the answer is no. And that's because we think often of obesity as a major risk factor for sleep apnea, but it's actually just one of the reasons that people have sleep apnea. Usually there are anatomic reasons that they have a small airway. They're more likely to have their airway collapse while they're sleeping. And so that might not be something that we can fix with weight loss. But what I would tell you is that you can certainly go from a more severe category of sleep apnea to a more moderate or mild, which allows you to consider other treatments that don't necessarily involve CPAP.
I think I have a question for Dr. Cooney, but I'll leave it all the other panelists as well. So I'm a vascular surgeon, vascular specialist, and I've practiced in Naples, in this community, wonderful community, for nearly 20 years. And I've been privy to much of the technological improvements in our specialty that allow us to help people walk with circulatory problems. But we've now transitioned a lot of our operations from open surgical procedures to minimally invasive. So as probably a lot of you know, we do a lot of femoral access procedures. So long-winded question, but is that something I need to be concerned about, or should I enjoyed your talk on mobility. Can that contribute to some loss of mobility post-operatively that we can improve upon?
If you can keep people out of a hospital, that's a very positive thing. So I think if you can do the procedure as an outpatient without an extensive time of bed rest, without hospitalization, we think that's very positive. I think the one thing to be aware, though, before you're doing any procedure on an older person, you should know something about their cognition. Because if you have somebody who has memory loss that a lot of people may not realize, and they get their anesthesia that they need, or they're just in the foreign environment of a post-acute care unit, a PACU, they can get delirious, and that's a big problem. So I think doing it as an outpatient with the more minimal procedure is a great idea, but I think any older patient that you're contemplating do surgery on, when I see someone we're thinking about doing a hip or knee replacement, it's much more important to know their cognition than to know anything else about that person. Because if they have cognitive problems, the likelihood of them becoming delirious around a procedure is very high. And that's a big problem.
Thank you. Any more questions?
You recommend 7 to 8 hours. Is getting 9 hours, is that benign, or do you lose something?
So I won't pull this slide up, but the National Sleep Foundation recommendations are 7 to 8 hours, but they recognize on either side that 9 hours may be appropriate or 5 to 6 hours may be appropriate. So we know that there are certain people, there are individual differences. So, right smack in the middle is 7 to 8, but just on either side may also be appropriate. And so I guess I would ask you to think also about the quality and not just the quantity of your sleep.
Are there any more questions for the audience? Excellent. Okay, well, a round of applause for our very fantastic panel this afternoon. I'd also like to thank Moorings Park and the Yale Club of Southwest Florida, including Mr. Hansen and Mr. Horton for organizing this event, along with Yale University School of Medicine. Thank you very much.